All right. Hello, everyone. My name is Elena with Forge Breast Cancer Survivor Center. Welcome. Thank you so much for joining us today for this special Ask the Experts coffee conversation. So we have the pleasure of having Dr. Jennifer de Los Santos here with us today to talk about radiation oncology, as part of breast cancer treatments. So Dr. de Los Santos, I want to thank you so much for being here with us today. Such a pleasure to have you. And I guess we can just start by asking you to just tell us a little bit about yourself.
Hi, so yes, I am a radiation oncologist and a former faculty member at UAB. I served on faculty there from 2001 through 2018 and left really as a fully tenured professor to take over as Cancer Center Director at Grandview. In that role and at Grandview, we have been able to continue our work sort of addressing the lack of clinical trial options maybe in the community for people who don't want to go downtown to UAB, and also opening up all kinds of programmatic pieces like support groups, not just for cancer patients, but also for providers. We've done a lot of work in the lung cancer screening arena, now have interdisciplinary clinics at Grandview with breast clinics and multidisciplinary nodule clinic for lung cancer. So really, my other big focus is really to open up a lot of research here, because I feel like since I've been out of UAB and in the community there, it's surprising to me how many people in the community really don't want to traverse downtown and are maybe looking for options where they can get next generation therapeutics sort of in a community setting that's easier to reach. In my role as a breast cancer researcher, I have continued my work nationally since I've left UAB, and presently serve on the AJCC 9th Staging Edition for breast, and am looking to continue some of my work through the cooperative groups.
That's wonderful. I mean, I drive down 280 fairly often, so I see just everything that's going on at Grandview as a campus, which is very exciting. And then to hear, all of the things that are happening within breast cancer specifically, and things that you're bringing to Grandview, that's incredibly exciting.
Well, thank you. We've really enjoyed working out here. I think we have some fantastic collaborating physicians. We have really great doctors out here now. And we started a huge women's imaging program out here as well. So, and some ex-UAB people are actually involved in that as well. So that's been really fun.
Yeah, a lot of movements. Well, let's start with a very basic question, because again, people are going to be finding this recording and may not know, maybe starting from the very beginning with a diagnosis for themselves or a loved one. But so what is radiation oncology?
Right. So radiation is a specialty that delivers radiation to cancer when indicated. And essentially what I like to tell people is radiation is energy delivered to the cancer that works by damaging the DNA inside the cancer cell. And when those cells turn over in their division process, they end up dying because we have damaged that DNA. Now, the side effects from radiation are very dependent on the cancer and where it is in the body. So X-ray therapy, which passes all the way through people, obviously hits some normal tissue. And so if you have a tumor deep in the chest or deep in the abdomen or deep in the brain, we have to pass through normal brain tissue or bowel or lung to reach those tumors. And so the side effects are really related to how those organs react to that energy. When it comes to breast cancer, and in terms of curative breast cancer treatments, so people that get lumpectomies or people that have mastectomy with more locally advanced disease, where radiation is still needed to prevent local regional recurrence, so recurrence within the chest wall or the reconstruction and those surrounding lymph nodes, what we're doing is essentially skimming a very shallow beam of energy across the chest wall. And so what we do with the radiation, or the side effects, are really soft tissue. So we get like a little bit of fatigue and a little bit of redness in the skin. A little sliver of underlying lung tissue is also included in that field. And so people will have permanent scarring there, and it can show up on chest CT, but it's such a low volume that people are not typically symptomatic. So the risk of pneumonitis or inflammation in the lung tissue from the radiation is less than 1%. So now, in left-sided breast cancers, the heart is on the left, and it is very important for patients to ask their radiation oncologist, how are you protecting my heart? Because there are different techniques we can use now in radiation. The therapy and the technology has really come a long way. So for people that are, and we see a older population here in general at Grandview than I did when I was at UAB. And so for older patients, sometimes prone positioning, lying on your tummy on a special board that allows the breast to fall through an opening, is a fantastic way to avoid the heart, and actually gets a little bit more lung out of the field as well. However, it's a more difficult position sometimes for our older patients to hold. And so because you have to have the strength to kind of, support yourself a little bit, and then shoulders, if you have arthritis, that can be an issue. And so the other way we set people up for left-sided breast cancers is on their back on a specially inclined board. And we have them take a deep breath in and hold it. And when they do, they expand their chest wall away from the heart, and we utilize that position to keep the radiation further away from the heart. And that is going hopefully to translate into lower risks of cardiac disease in the second decade after radiation.
Oh, wow. See, I'm learning so much just about the different techniques and how to make adjustments, right? I mean, obviously every breast cancer is unique. Every
Yes.
individual is unique in what they're able to do and where it's located and all of that. But knowing that your physician has different tools and techniques, and that, radiation is not a one size fits all. It's very much so catered to what's going on, and then what that person, is able to physically do, at the time of radiation is what it sounds.
Yeah, and there is a lot of training and technique involved with radiation. So, a lot of times if we see people who are from, outside Birmingham, and they've asked, can you prescribe the treatment and tell my doctor that is closer to home what to do? We tell people, well, there's, I'm getting some feedback. There we go. Thank you. Thank you, babysitter. A lot of times we'll tell people to ask so it's very similar to a surgeon telling another surgeon, hey, this is how you need to operate. Well, we can't tell people that. They're going to do it the way they're trained and they're comfortable. And there's, obviously equipment involved. So not everybody has a prone board. Not everybody is doing these new techniques. When we do the deep inspiration breath hold, we also image people daily on the machine with left-sided breast cancers. We do it on both sides, but especially for left, to ensure the radiation's off the heart. And so, those are very important questions to ask your providers, because not everybody has the same equipment. Not everyone is trained the same. And just like a surgeon can't tell another surgeon, well, this is how you do it, because their technique and their training could be totally different, and they're not going to be able to execute that the same thing with radiation. So again, those are just important questions to ask your provider.
Yeah, absolutely. What are some of the other kind of factors that should be considered when deciding whether radiation is appropriate for someone's breast cancer?
Oh, absolutely. So, we were, before we started the conversation, we were talking about research, and we were talking about what are the advances across the field in regard to breast cancer research. And there's been tremendous advances in the therapeutic space. So there's tons of different therapeutic options now for different kinds of breast cancer in the drug space that have really significantly improved survival. A lot of what we have done in the radiation space in terms of research is twofold. One is to see who really does need the radiation, and can a subset of patients defer radiation and not undergo radiation and still do okay. And so that is one question that multiple studies have addressed over the years, dating all the way back to the first publication in 2005. So the CALGB trial, the PRIME2 trial, more recently the Lumina trial, which was presented at ASCO this past year, have all focused on a patient population of ER positive, lymph node negative, HER2 negative patients in the more updated studies with small volume disease, again, that could go on a blocker of the hormone and not get radiation. And the more recent data with the Lumina trial show that patients that have luminal A type looking cancers, and those are subsets of cancer that are typically seen in older patients, although younger patients can have them as well, that are more indolent and more favorable in terms of prognosis. And so that group of patients we've now found on the Lumina trial, and that trial, I believe, tested people 55 and older, looked at so a younger population than had previously been tested, showed that if you deferred radiation, but you kept taking your blocker of your hormones, and that's very important because if you drop that piece, your risk of recurrence goes up. And that was about a 0.5% per year risk of recurrence, and it was cumulative over time. Now, the Lumina trial only has 5 years of follow-up. So we'll need to look going into the future, what, those patients, what their risk of recurrence is long-term. And so far, we do know that ER positive disease has ongoing risk of recurrence. And so we're watching that data closely, but we now have expanded the range of age that we can offer deferring radiation in.
Interesting. Okay. I was actually in a conversation the other day with someone who had had a lumpectomy, but didn't have anything else. So no chemo, no radiation. And then someone else in the conversation was surprised, with the assumption that a lumpectomy kind of immediately meant that the person would also have radiation. So it sounds like, again, another example of everyone's breast cancer being unique, but it sounds like there's a lot that's happening within the field of really paying attention to that individual and their risk and what's going on, and deciding whether that's needed immediately just because, a lumpectomy occurred, or if it can be, maybe done later.
Yeah. The one thing I just heard that makes me a little concerned is, I think that the key to deferring radiation safely is also to go on that blocker of the hormones. If you stop the blocker of the hormones, that risk of recurrence tends to trend upward to a level that we feel is not a safe option. And so what I tell people is if they're interested in deferring radiation, and they start on the blocker of the hormone, but the side effects are such that they're going to stop it, even though we don't recommend that they should come back and rediscuss radiation with their radiation oncologist so that they don't end up, the next year with a recurrence in the breast. And I have seen that happen over time. It's not something we want to see happen because, the risk of having a further problem goes up as well.
Okay. Now, this may be a very silly question, so I apologize, but it typically has sounded like radiation is something that occurs like post-surgery, right? So like post-mastectomy or post-lumpectomy. So when the tumor has largely, hopefully been removed, clear margins and all of that. And so the radiation is addressing recurrence.
Yes.
Or any like last little pieces that may not have been known kind of at the time of surgery. And that may be too broad of an understanding, but is that kind of?
That's more typical. There are situations where we treat people in the preoperative setting. They're not as common, but people that have inflammatory breast cancer or another very locally advanced process that is not responding to upfront drug therapy, where people present and they are not a surgical candidate upfront. And yet when we do the drug therapy, they're not responding as well. Those patients will often be candidates for neoadjuvant radiation. So we'll treat them in the preoperative setting and more than 80% of the time be able to convert those patients to operable. And so There are some very bad subsets of cancer that we still see where on occasion we do need to start with radiation. But fortunately, that is a shrinking number with our great therapeutic options that we have in terms of drug therapy.
That's wonderful. That's wonderful to hear.
Yeah.
Okay, in terms of symptoms, I know you spoke a little bit about there are techniques that can be used when delivering radiation to try and minimize any symptoms that may be experienced to organs and to, healthy tissue. What about like what other symptoms like the burns? Like what are ways that individuals can manage those from their radiation treatment?
Yeah, sure. So, for patients that are getting breast conserving therapy, they typically end up with a mild sunburn. And again, technique is also part of this. So, I have lots of patients that come in and say, wow, I'm really worried you're going to burn me up. And I tell them, we pay very close attention to when we plan the radiation to the distribution of the energy, to the hotspots in the field. We utilize the latest technology to ensure that risk is minimized. But for sure, they're going to have a little bit of what we call a mild sunburn. So we have all kinds of creams and skincare regimens that we recommend. And when we see people under treatment, so you should be seeing your radiation oncologist once a week at least if you're undergoing treatment. That's actually standard of care. And when I was at UAB, I was aware of some groups around Birmingham or around Alabama that weren't really doing that, which is not good and it's not okay. And if they're billing for it, it's actually Medicare fraud. So that's really not okay. So I want everyone on the call to know that in fact, you should be seeing your rad onc once a week. And when we see people, that is we talk to people up front and give them packets of education about how to take care of your skin. But we often will just go ahead in under treatment clinic and add new regimens or products that will be helpful at the time, specifically addressing the symptoms. So sometimes in addition to a little mild tenderness in the breast and redness in the skin, they'll have itching. So a little steroid cream is great for that. We also have a product, we love the hydrogel wound dressings that are out there, like the Lindy products. There are some really great, just very basic things I've taken from some of the dermatology practices. We start our patients on water vinegar rinses. So I tell people a quart of water and a tablespoon of white vinegar, keep it in the fridge, mix it up, clean off the breast twice a day, very cooling and soothing, and then apply the cream afterwards. And that does a really great job at helping get them healed up quickly. So
okay.
Yeah.
See, another trick that I had not heard of before.
Yeah.
Wow.
There's also, for the people that are getting mastectomy and have expanders and are getting reconstruction, but they have a more advanced cancer that requires radiation. When people are done with radiation, there are some medicines we can put people on that interfere with that scarring pathway active after radiation and will allow the changes that we induce to soften better over time. And there's randomized data with this now too. So there's a medicine called Trentol or pentoxifylline that I give with vitamin E. And we also use a little Singulair in patients that are either have an expander or are getting an implant that will help a little bit in regard to reducing contracture. So when you have a foreign body in you, it creates a scar. Your body kind of walls off that process, and it causes the implant or the expander to feel hard, and that is normal. And so these medicines, hopefully over a year after the expander is placed, the goal of them is to really change that microenvironment, improve it. So when you have your expander removed and your final implant put in place, that microenvironment is optimal, is better for long-term success of that reconstruction.
Oh, wow. Okay. Yeah. There are a lot of pieces to it, aren't there? That I know that I didn't know.
Yeah, there's subtle things that in regard to management that can improve outcome.
Yeah.
So
Well, what about, because I know that this is a hot topic, and I know that Frankie had mentioned it when she first joined on, but lymphedema. So
Yes.
radiation and lymphedema, what's that link, and what are things that an individual can do, knowing that they have to start a radiation treatment?
Sure. So first off, lymphedema is a process that creates, or what it essentially is swelling in the extremity on the side of the cancer. What happens, and the reason people get lymphedema, is that when we do treatment to the lymph nodes surgically with radiation or with chemotherapy, it creates a scar in that area. And the way I explain what lymph nodes do, in addition to fighting disease, the lymph nodes are they're almost like little cities. So they're little structures that are all over your body. And the lymphatic channels, which run along with your vessels, your arteries and your veins in your arms, legs, everywhere. The lymphatic channels follow those vessels, and they're one way to get fluid, extra fluid, from all over the body back into the central circulation. So if you have a river flowing up to a dam, what's going to happen? It's going to back up the water. And the same thing happens when we treat the axilla. What we have found is that surgery probably is the biggest offender in regard to risk of lymphedema, but radiation and chemotherapy also contribute to it. And chemotherapy does as well, because it actually hits the lymph nodes as well, creating some scar. So all of those things contribute to it, but the surgery is probably the number one contributor to it, which is why we've moved towards sentinel node procedures. And that allows us to remove less nodes through a procedure where we inject 2 separate dyes in the breast that drain to those lymph nodes, and allows us to take out those high-risk lymph nodes that are lighting up. So basically following that pathway the tumor would drain and capturing the lymph nodes it drains to, so that we can just remove a few to accurately stage somebody. Now, I have to tell you, nationally, the trend has been to really almost move away from sentinel node. We do not do it in DCIS, and nobody should be doing a sentinel node in DCIS. In patients with microinvasive cancer, the risk of lymph nodes involvement is less than 3% as well. So, and now nationally, and this has been something that's been proposed for quite a while, probably at least 8 years, there are studies ongoing in Europe. They're looking at whether we can avoid sentinel nodes in early stage luminal patients that are clinically node negative, and especially, if they're getting radiation, although some of the studies avoiding radiation did not have axillary staging as well. So I think that trending wise, we are sort of moving away. We're moving toward less surgery in that arena. The risk of lymphedema, though, can be very significant, and especially if somebody needs an axillary node dissection, if they present with more locally advanced disease and have multiple nodes involved. And if you look at the studies, subclinical and clinical risk could be as high in patients that have full axillary node dissections, chemotherapy, and radiation can be as high as 60%. When you are, very sensitively measuring extracellular fluid in the extremity, okay? In terms of overt lymphedema, it's probably more in the 30 to 40% range. Up until recently, we've only had the ability to control lymphedema with compression. And in some cases, Lasix or other medicines that help reduce fluid through the body. We do know that there's been some updated studies regarding lymphedema. We used to tell people, oh, wear a sleeve when you fly, don't get blood pressures on that side, don't get blood draws from that side. And that has been debunked by a study that was published probably in 2012 in JCO. So the Journal of Clinical Oncology, which is one of the big journals in oncology, showed that the blood draws and the blood pressures on that side really didn't increase lymphedema. What does increase lymphedema that we know of is infection. And so it's very important to protect that arm in terms of infection. Now I'm going to throw one more thing out to the audience to alert them to a developing procedure that I think in the future may have big potential to reverse lymphedema, period. And that is lymph node transposition. And we have known about this for a while. There is a study going on right now, I know at MD Anderson, looking at this, and it involves taking a lymph node from another place in the body and transplanting it into the area where those lymph nodes were removed. So on the side of the breast cancer. And doing that, it seems that the reintroduction of lymph nodes in that area may be able to reestablish flow. And there have been some reports now of people who have had very significant overt lymphedema, having lymph node transpositions and having the edema completely resolve. So we are interested in getting a study opened here at Grandview in that regard, and we are looking very carefully at the data to see how this all shapes up, because that would be huge for patients who have lymphedema if this can truly reverse it.
Yeah, I mean, wow. I'm floored. I know that so much has changed when it comes to breast cancer treatment. I mean, just even hearing the stories of individuals, who were treated in the 80s, 90s, and the experience they had, and what they're facing now. And so just to hear kind of all of these things that are still happening. I mean, it's not like this is what it is and there are no more advancements and this is the best that we've got. I mean, there's still so much that's happening to improve, to treat what is needed, to not treat what is necessary or what is unnecessary, and all of that. What about, I know that, I mean, there may be other advances too that you'd like to speak to, but I know one thing that we have fielded some questions about, or that people have been curious about, has been proton therapy.
Yes, so protons is a form of radiation called particle beam therapy. Protons are for those of you who remember your science class, a molecule is made up of protons, neutrons, and electrons. The protons and the neutrons are in the nucleus of the atom, and the electrons are like the little planets circling the sun. Protons have a very specific property that makes them advantageous in certain situations. So a proton beam delivers radiation by entering into the tissue, and then at a given distance delivers all of its energy in one fell swoop, and it's called the Bragg peak. And that advantage means that everything past that point does not receive radiation. And so for patients who have a tumor up against a very critical structure that is sensitive to radiation, it allows treatment of that to higher doses, but still protect that normal structure behind it. In regard to breast cancer, there is an ongoing study that has looked at IMRT, which is intensity modulated radiation therapy, which is photons. So it's actually X-ray therapy, but delivered by a computer that generates a distribution of dose to the target that is sort of high dose, and limits all the surrounding normal tissue to much lower doses. That is being compared in patients who have mastectomy and who need their internal mammary chain nodes treated. So the lymph nodes that lie next to the breastbone, sort of in the first three inner spaces of the ribs, so the very top of the breastbone. We know that breast cancers, especially lymph node negative breast cancers, and ones that lie on the inside aspect of the breast, are at higher risk for having drainage to those lymph nodes. They are not taken out, they are not sampled, and if they're at risk, they have to be treated. But by treating them, because of their location, they're a little deeper, we end up having to use a slightly deeper beam, and there is more heart dose in that situation. And so the question is, can we use a proton beam to treat the internal mammary nodes and the breast itself, and get a better dose distribution and hopefully long-term less toxicity in comparison with this IMRT approach? And so more more on that. I think what we definitely know that people that have poor cardiac anatomy, and by that we mean people whose hearts really lie right up underneath their rib cage, and they could be enlarged, or it might just be an anatomic variant, but makes it a little bit more challenging to avoid the heart, even with a deep inspiratory breath hold. Sometimes we still have that. And so I think that those situations are situations where we know protons, even in that setting, do give a little dose to the heart. And that's why the data are so important. We really want to see how that's going to impact that group long term.
Mm-hmm.
But for most breast cancers, we can do a great job with photons. And actually, one of the downsides of protons is it does give a little bit higher skin dose. And so you are going to get a little more reaction. You know, in the post-op setting, I suspect you're probably not having to replan protons a lot, but in somebody who had an intact tumor, for instance, replanning, because the proton beam is so specific, has to happen at multiple intervals over the course of radiation. So it's very work intensive.
Mm-hmm. Okay.
So
yeah, that's very helpful to know, and very easy, you know, for you to explain too, which is wonderful, because I have heard a number of people who've been interested in proton therapy, but maybe their insurance wasn't covering it. But again, it has its pros and cons, right? And so if depending on the location, if it's something that would be more beneficial for that unique breast cancer, then, you know, hopefully that's still an option. But otherwise, you know, as radiation as it has been done, you know, is still a wonderful resource.
it is, you know, one of the big challenges with protons is it is so expensive, because the facility that's needed to deliver a proton beam, you need a cyclotron. And so it's a very, very large machine inside a huge concrete bunker. And the protons, because the machine itself, it used to be about $120 million for a proton facility. It's less now. Like, the cost has come down a little bit as more people have added these technologies. The only proton facility, by the way, right now in Alabama is a UAB. UAB does have a proton facility, but it is very difficult to get insurance because it is so expensive. It costs more to get protons, and insurance companies routinely deny protons for many different kinds of cancer. So, you know, UAB is doing studies like a lot of other institutions to really define who really truly needs that technology.
Mm-hmm.
But in general, for our patients in Alabama, if you need the protons, we send people to UAB. We don't have a problem doing that. Most breast cancers don't really require protons. We can do this safely, effectively with photons. I suspect many patients, if they went down there, their insurance may not pay for it, and it's extremely expensive. It's not something that most people could come out of pocket for.
Yeah.
And, you know, if there's not a big advantage, a lot of the sites that have tested, you know, sort of this IMRT versus protons have shown in some settings a lower toxicity, but not an advantage in survival. And so it's really important to talk to your doctor about, where's the data at? Is there advantage? And if there's not an advantage, you know, maybe looking at the facility in terms of what their capabilities are of delivering excellent photon therapy.
Mm-hmm.
But in general, because of that insurance approval, it also delays care. So if you're interested in getting protons, or if your doctor says, hey, you are the person I think that needs protons, be patient, because I think once you get in and the planning process gets going, that it may delay it a week or two, or even 3 weeks just to get insurance approval.
Boy. Yeah. Well, I have two more questions, but I do want to watch our time and make sure that we have plenty of time to talk with our audience who's joined us here live today. But what about for those with stage 4 breast cancer, the metastatic community?
Thank you for
What
bringing
does
that up. Yeah.
radiation therapy look like for that population?
Yes. And so there are two. So in my role on the AJCC staging committee, I also happen to know that we have just divided the stage 4 cancer patients into 4 categories, because stage 4 is such a, what we call heterogeneous group, meaning that people vary widely on their outcome and how they do with stage 4 cancer. There are some patients who have ER positive cancer with bone mets only who live 20 years with stage 4 disease. And then there are people that have this really horribly aggressive triple negative breast cancer that can die within a few weeks. I mean, with stage 4 disease, there's that range. And so we've now identified 4 subsets of patients. And so with that, I think it really depends where people present and how they're presenting. So importantly, there's 2 categories I also like to talk about with stage 4 disease. There's oligometastatic disease, and this is a term that defines a group of patients where on scan we see in some studies 4 or fewer, or now in some studies 5 or fewer metastatic sites. And in many different cancers, not just breast, but colon and prostate, pancreas, a lot of different kinds of cancers, we have looked at whether we can ablate those 5 sites, because we know that, or 1 to 5 sites, and improve survival, because we know that in patients that have solitary metastases that occur after they have their treatment and have control of the disease at the primary site, that in some cancer populations, there is a survival advantage. And in fact, 1 out of 5 patients with a solitary met that have surgery or have this ablative radiation called stereotactic body radiation or stereotactic radiosurgery, that can be curable in 1 of 5 people. We just had a study that was presented that had been ongoing at the cooperative groups. And this study was presented at ASCO this past year, so just a few months ago, BR002. And it did not show a survival advantage, interestingly, in breast cancer. However, I suspect, and I happen to know, it took a very long time for us to get the events, in other words, the recurrences on the study that we needed for us to do the analyses. What I think is happening in breast, and I could be wrong about this, but I think this is probably true, is we are doing so well with the systemic therapies. We have just come so far that people are generally living longer. And I think it's diluting some of the benefit we're seeing from the stereotactic body radiation. However, we also have a new study that was just presented a couple of days ago at Astro that show that asymptomatic bony metastases that are addressed early with radiation can improve survival. So in other words, if people have a bone met in a hip or a spine, a portion of their spine on the vertebral body, there's sort of high risk areas, or in their femur or their humerus, areas at risk for breakage if the cancer continues to grow. And even if they're asymptomatic now, and we address, the study was out of Memorial Sloan Kettering, it was a phase 2 trial. If we address it with radiation early, they found a survival advantage. And so people are not only having an improvement in outcome from quality of life, because they're not going on to have a cord compression from the spinal cord being pressed on by tumor, or have a break in their leg or arm because of the tumor, but it is actually translating into better survival. So I do think radiation still plays a very important role. And obviously in the palliative setting, it's also very important to relieve pain. I know for brain mets and a small percentage of patients with breast cancer, more so triple negative, HER2 positive, but we also see some luminal B cancers that go to the brain. That stereotactic radiosurgery is also an extremely effective way to deal with those tumors that spread to the brain. So.
Well, again, it sounds like such exciting things kind of happening in the radiation space. And I guess when it comes to individuals with metastatic disease, I mean, you're obviously talking and meeting with your doctors very regularly to monitor and, see kind of what's going on and what could be done, for survival and quality of life and all of that. And so I guess my last question really is, what are some of those questions, not just for metastatic disease, but, for anyone who's facing breast cancer treatment with radiation therapy, like what are those questions that you really want to make sure that people are asking either before, during, or after their radiation treatment, again, to just help them improve outcomes, live better life and all of that. So that's my last question for you today.
Yeah, so I think whenever somebody goes in to talk about whether they need radiation, they should know why they're getting it. So what are the goals of therapy? Are the goals, is this treatment only going to reduce the risk of the cancer coming back in this area? What is that risk? What is the reduction in that risk with the use of radiation? That's number one. What is the survival advantage, if any? Is there a survival advantage? What options are there for deferring radiation? Am I a patient eligible to avoid radiation? And that would be, we're talking about the curative setting, in breast conservation or mastectomy. And then, what techniques do people have, and especially in left-sided breast cancers, to avoid the heart? And that is really important because so many people, I think, obviously presenting with left-sided breast cancer, there are still groups that are not doing those special techniques to avoid the heart. And we know that if you treat the heart or give higher doses to the heart, and there's more and more data on defining what that is, we know what that is, what doses we should be staying under to protect the heart from disease after treatment related to the radiation, that you should be asking your doctor about that.
Well, Dr. Los Santos, I want to thank you so much for your time today and sharing this. I feel like we could talk for hours,
Yeah.
many more hours about kind of what's going on now, what's hopefully happening in the future. So I want to thank you for this conversation, for making this available for individuals through video. And so I'm going to stop the recording now so that we can have a little conversation with our participants. Thank you again.
Thank you.